When I talk about pain, what is the definition of pain? When you call this patient, there are 4 patients or 10 patients in the ICU, each will have a different subjective feeling. So definition which is given here is an unpleasant sensory and emotional experience. By experience means it is subjective. The moment they put the term experience, that means the pain is very subjective to all the patient. So unpleasant sensory and emotional experience. So emotional you can't see, but the patient may be feeling. Associated with actual or potential tissue damage means either it has damaged something, there is some injury, or it has a potential to cause damage, or describe in terms of such damage. So by this definition, you need to understand that it also carries an emotional thing, plus there is an unpleasant thing, it could be sensory, and this is an experience, and it has the potential to cause damage. So why this definition becomes important in critical care? So it occurs in patient whether or not they can communicate. Means there are chances that you have a patient or ventilator. So even if they are not communicating, you are not telling, they may experience pain. Therefore, we need to look for it. It is an experience specific to the individual. One patient may feel that pain, other patient may not feel that. So you need to look for the pain, you know, to look for the subjective feeling. One particular dose of drug may not be sufficient for all the patient in the ICU. Okay. So how it is common? If the pain is in the ICU, is there, okay, we need to find out. But if it is not common, what's the point of discussing on? So many healthcare professionals feel that if mechanically ventilated patients are usually on fentanyl or some sort of, so are they not comfortable? They are okay. So in studies, they found that approximately 30 to 50% of the patient experience pain at rest. Even if they are doing nothing, they are simply lying on the bed. 30 to 50% of the patient experience pain, and during procedure, it is beyond 50%. And the important point was the difference between medical and surgical patients or trauma patient was similar. Why? I will tell you. Now, even if you identified that pain is there, so what is the consequence of the pain? If it is pain is simply doing nothing, if it is not harming, what's the point of discussing? Even you have identified pain if it is there. So if it is not doing any damage, then what's the point? So what are the consequences of the point? Now in the study, when the patient got improved from the ICU, they followed the patient, they asked them, and they found that patient frequently 20 to 60% recall that they were in the pain during the ICU. And most finding to pain have been significantly stress and bothersome. It was very bothering to them when they were more than out of 10, 6 patients were saying that we experienced some sort of pain during our ICU tour, and it was not comfortable. So only this much, this emotional thing was the only concern, or it has got some effect on your treatment part. So pain and the stress response are known to have physiological consequences. What are the physiological consequences? They increase the stress hormone, there is vasoconstriction, decreased tissue perfusion and healing, mood impairment, impaired immune function, hypermetabolism, lipolysis, proteolysis, excessive muscle tone, and hyperglycemia. So these are the factors, these are the things which the pain can influence. It has delayed wound healing, impaired immune system, increased proteolysis, catabolic state. You may still have seen that hypertension, tachycardia, all those things are. So these are the physiological parameters. Also psychological consequences: chronic pain, traumatic pain, post-traumatic stress disorder, and over a period of, you follow for 1 or 2 years, the quality of life is also affected. So that's why it is important we should address this pain in the ICU so that we deliver the best outcome to the patients. So when this pain occurs, so pain usually occurs, we divide it into 2 categories. One is in the rest and the other is during some procedure. So rest means patient is lying on the bed and is experiencing pain. So most of this type of pain occur in the post-surgical patients, either surgical or injury patients. Surgical ICUs people, they have different range put there, they have gone through surgery, so or trauma patients. So these are the pains at the rest which is present. Like post-TKR patient, they have got to go, they say that they are having pain. Other sources are back pain, lying for longer period of time, limbs, back pain in the limbs, abdomen. Even when your abdomen starts functioning, your bowel starts moving, there could be spasm, there could be constipation. The site of ICU illness bleeding or the endotracheal tube. indwelling tubes, catheter, medical devices, drains are there, lines are there, artery line is there, ventricle tube. So these are the pain which are present even if the patient is doing nothing, you are doing nothing, you are doing many procedure, but the patient is experiencing pain. Okay. Now pain at procedure pain. So a lot of procedures are going in the ICU. Routinely peripheral line insertion is also a procedure. You don't give a local before inserting a peripheral line. Artery line, central line, chest and wound drain removal, not insertion. During insertion, you give the local anesthetics. While removing the drain, you don't give a local. Tracheal sectioning. I have never seen a single patient in which while doing tracheal sectioning, anybody giving an analgesia to the patient, and believe me, it's very painful. Whenever the tube, the suction catheter touches the carina, it's very turning the patient, mobilizing, physical therapy, wound care. These are found to be very painful. So these are because these are done without little or no analgesia. So out of all this, chest drain removal, wound drain removal, whenever you are removing to arterial insertion, I've seen many residents that they don't give local while putting the arterial line because they feel that it will disturb the landmarks. Suctioning. So these are the three things: wound, drain removal, arterial line, and tracheal suctioning. These are the things which are associated with a lot of pain. While other mobilization, positioning, turning, these are associated with mild pain. But this is to give you an idea of why it is not that whenever patient is complaining, he or she is experiencing. These are the things which are very routine in the ICU, and these are the things which are causing pain to the patient. Rest and pain. So what are the risk factors? So we have discussed that it was a subjective feeling. So before any procedure, if the patient was complaining of pain, that is subjectively it has got a low threshold for sensitivity of that pain. So a risk factor procedural pain was high procedural distress, highlighting the importance of good pain management. Also, if you need to give fentanyl or opioid during the procedure, that means the pain management before the procedure was not appropriate, and we need to, or assessment was not appropriate, and we need to increase the dose during the procedure. Now, regarding medical and surgical ICU patients, in surgical patients and trauma patients, what they feel that because we have done a surgery, they are usually prescribed the painkillers post-operatively. But medical patients, septic patients, or any COPD patients, or some other patients for that, in better neuro patients in the ICU, don't prescribe painkillers or routinely or something like that. So that's why whenever studies they do, they found that the medical patients have a little higher pain things in the ICU. But the point is, because they are not assumed to be having pain, they are less prescribed the pain medication. So that's the thing. So perception of pain is common in both medical and surgical units. Only thing is the way you treat in both the units is different. The importance. So we have seen why it is important to identify the pain, because once you identify that this patient is having pain, and once you have identified this pain can have physiological consequences and a longer term emotional component in it. These things, when identification of pain should trigger that we need to objectively measure this pain in such patients. The importance is regular systemic assessment of the pain should take place, because it is usually underappreciated, under-recognized, and under-treated. Okay? So you need to have a good knowledge about the analgesic properties. But point is, you need to start objectively measuring this pain.